Some of you were in the talk yesterday of our basically describing our research, but I'm going to pare down a little bit more today about what does it really mean and who cares, and then talk a little bit about the resistance training study. But we wanted to start off with Dr. Dominic Reed's son. He was actually a healthy control participant in our study in St. Louis, and I'm getting too close to that speaker. So I'm going to let him start off and just briefly tell about his experience.
Hi, my name is Nicholas Reeds. I just signed up for the study because when my dad told me about it, I didn't think that it was fair for other kids who had heart failure. So I wanted to help doctors find a cure for the disease.
Okay, great. So again, I know a bunch of you came by yesterday and saw our talk, but we wanted to talk about some of our experiences with the clinical research. So a lot of you know that we were funded to do really the first clinical research study in Barr syndrome, and looking at how these boys metabolize nutrients, fats, sugars, proteins. Nicole talked a little bit about that. And how does that relate, or how does that associate with their heart function and how their skeletal muscles in their hearts generate energy. So we're almost finished with this study. So we're in year 5 of this study, and we've been super successful, great participation. We've only needed a few more people to complete this study. And we think this is really important because, first of all, it tells us a lot about the disease. Really helps us phenotype, in a sense. You hear a lot about genes and genotype, but it really shows us how we know a lot about what's going on in these cell lines and these yeast models and these Barth mouse models, but how does that truly translate into the human being? So that's what this study was about. And we hope that we've identified some good clinical outcome targets. I know that Brittany talked a lot about the 6-minute walk test, but there's a lot of other things that we can look at that could be potential good outcome measures for these different therapies that we're talking about. So why did we do this study? Well, we know that the TAS deficiency, the mutations in the TAS gene, leads to these alterations in cardiolipin. And cardiolipin is very abundant in the mitochondria, and the mitochondria are very abundant in the heart and skeletal muscle tissue. So obviously, these are the tissues that are most affected. So really, we wanted to look at how these tissues that are so important in generating energy, right? The heart needs energy all the time. The skeletal muscles need energy, and this is deficient in the Barth boys. And that's really shown in the clinical complaints: excessive fatigue, which a lot of boys have, activity intolerance, not able to participate in PE well, and things like that. So we really wanted to try to figure out why physiologically are they having issues in their heart and their skeletal muscle and not being able to participate in these things. And it's a really young disease. If you think about the different types of diseases that we know about, Barr syndrome really in the early 80s was identified, so we still need to learn a lot about the disease. So really, my interest and my thoughts on this area really was generated in 2006 when I collaborated with Carolyn Taylor and Barry Byrne on this study looking at exercise tolerance. So we knew a lot about subjective reports of exercise and fatigue. And what we did is we used exercise testing. I'm sure a lot of your boys participated in this study, really quantifying their exercise tolerance. And what we use is that graded exercise test where they get on the bike and they're hooked up to the EKG and they have this mouthpiece and nose clips. Again, a lot of you are probably familiar with that. And we're able to tell how much energy they're able to generate through using oxygen, aerobic energy. And we're able to do that. And as a lot of you know, this was published a few years ago, that the Barth boys, this is the open circles here, had a severe limitation in the ability to generate aerobic energy, where the unaffected boys had a much, much higher level. And they were only able to, this is work rate, so really how hard it is to pedal the bike, severe limitation compared to unaffected boys. So this is the first really study to quantify their exercise intolerance. And one of the things we looked at that I saw that really struck me was this measure that when they were doing this exercise, again, this is the same work rate, same bike test, and this is a measure of how much carbon dioxide they're producing over how much oxygen they're consuming. And as you see, this is the unaffected boys, and it's a pretty low level. It increases a little bit as you increase in exercise intensity, but as you see, it skyrockets in the Barth boys, and I've never seen that in any clinical population that I've worked with. And that really struck me that these boys were using different energy substrates rather than using aerobic energy. And that really struck my interest in applying for a small BSF grant where I was able to get preliminary data to apply for it to the NIH to get this RR1 that we're working on. And really the idea of this study is to look at how the heart and muscle utilizes fat and sugar and protein. And if that's defective, how does that contribute to this exercise intolerance and potentially heart dysfunction? And we hypothesized that the ability of the heart and their skeletal muscles to use fat is severely impaired, which we believe increased the heart and muscle protein breakdown, thus using more of these protein and amino acids and glucose, so sugar, to supply their energy. So they're not able to use fat well, so they have to get the energies from somewhere, so they use sugar and fat, which is not normally used to generate energy. And because amino acids and sugar really provide an inherently lower amount of energy, that there's going to be a deficit. And then we think this deficit results in exercise intolerance and decreased heart function. So that's really what we wanted to study. So what we did is we wanted to look at 30 guys with BART, so 15 kids and 15 adults, and then controls. We wanted to look at what healthy kids, how healthy kids and healthy adults metabolize these and how that related to their energy. So what we did is we brought them to St. Louis. If they were a child, they were there for about 3 days, and if they're an adult, they were there an extra day. And what we did is that we did this peak exercise test just like I showed you. And then we had 2 separate days where we actually gave them a little bit of fat, a little bit of sugar, and a little bit of protein as a tracer, so naturally occurring in foods and things totally safe, not a drug. And by taking blood samples and breath samples, we can tell a lot about their metabolism. So what we were interested in doing is not only measuring this at rest, we wanted to give them a little bit of exercise to see if that changed things. And that was really important that we thought. So what we did is we exercised them at 50% of their peak ability, peak exercise tolerance. So for you and I, that would be walking down the street at a brisk walk. So a low level of exercise. Probably a lot what your children do on a daily basis. And then we measured this for an hour afterwards. And then we basically gave them a fat, we gave them glucose, and we gave them an amino acid. So we looked at metabolism this way. We also did an echocardiogram to look at their heart function. We also used MRI. So it's a special type of MRI that actually can look at how the heart and skeletal muscle generate energy. And then the adults did this specialized heart metabolism study where we actually use radioisotopes. So we use radioactive isotopes, and then we basically imaged the heart. How much of fat, how much glucose, and how much amino acid was the heart actually taking up and utilizing for energy. So I'm going to have Dominic Reeds talk a little bit about some of the techniques.
All right, thanks, Todd. For those of you who don't know me, I'm Dominic Reeds. My background is in clinical nutrition and metabolism, so I think we're doing a session later today about nutrition and hormones in kids with BART. I've been working with Todd for more years than either of us care to remember, and I've been working with him in BART syndrome for about the last 5 or 6. And so I know a number of the children in this room have participated, at least one of my sons has. And so I wanted to tell you a little bit about the horrible things we've been doing to your children and why we've been doing them, other than glee. So this sort of futuristic, almost looks like a Tesla or something, Elon Musk kind of a thing, is called a bod pod, which is also a kind of a cool name. And what it does is it consists of a couple of membranes. There's a little window so the person doesn't go completely insane while they're in there. And it consists of a very accurate scale, so we can measure exactly how much somebody weighs. And then it's divided into 2. You can't see in the back half here, there's a little membrane that measures the air pressure. So what it essentially does is the child sits in here, the adult sits in here for a relatively short period of time, 10 or 15 minutes. And by applying a little bit of sound, it can measure the exact volume of the person. So you can figure out how dense somebody is, which for people in politics is very dense. For the kids is actually not so dense. So what this information does is it lets us use relatively safe methods. So rather than using a DEXA machine, which requires radiation exposure, it allows us to very safely measure how much fat and how much lean body mass, or how much muscle each of these children actually have in their bodies. So this is an important thing because the mouse people were talking yesterday about the skinny phenotype and the non-skinny phenotype in BART. We know that there is no skinny phenotype in BART. They may look like they're thin, but they still have proportionally less muscle mass than they should, even no matter what they look like on the outside. So that's the information that 5 minutes of testing provides us from here. This is Nick, and this is the real brains behind the operation, Kay, who I'm sure some of you know. And so what we're doing in this very complicated slide is we know that the lungs take in oxygen, and that goes into your body, and your body uses it to produce energy. And depending on what it's burning, whether it's burning sugar or whether it's burning fat or whether it's burning lactate, like when you're getting really exhausted, it produces progressively more and more and more carbon dioxide. So what we can do on this, so Nick's on the exercise bike here, so we can see how fast his heart is going. This machine is collecting his breath. And so by collecting his breath, we can see how much oxygen his body can take up and how much carbon dioxide he produces. So it not only lets us know how hard he's working, so if they don't do a good job, we can put you back on this machine. I have done it before. Not to any of the kids. The kids are always great. They really work hard. And what it also does is it tells us how much carbon dioxide they're producing. So we can see how the fuel sources that are used in exercise are different. So in you and I, we have to work fairly hard to become acidotic and to start, hitting this lactate threshold. A lot of the kids with Barth syndrome develop this just walking across the room. They live right on the edge of this all the time. And so this relatively simple test, this is the worst part, having the mouthpiece in, again gives us an idea not only how much oxygen the kids can take up, but what particular types of fuel they're using. So we can then plug this in. And so this is a somewhat complicated slide, but if you imagine that when you're exercising, your body, when it's going slowly, is using fatty acids. And then the harder and harder you work, you have to use more and more glucose until you start producing lactate. And the lactate goes back to the liver, and the muscles can also release amino acids and to produce more glucose. So we know that the children who suffer from Barth syndrome probably rely more on glucose because they have this trouble with their mitochondria and burning fat. So we think that probably at least part of the reason for this, and part of the reason for the loss of muscle, is that they're releasing more and more amino acids all the time to try and make glucose. And this has really been a focus of Todd's work. So what we're infusing into the kids and into the adults when they're doing these studies are non-radioactive traces. So everybody's heard of carbon-14 for carbon-14 like dating of objects. We use carbon-13 and hydrogen-2. So these are all non-radioactive. They occur in very, very small amounts in nature. So what we can do is we can give you a known amount of glucose, and it goes into your bloodstream and it mixes up with the glucose that your body is making. And we can figure out of all of the blood, how much of the sugar is coming from your body and how much is coming from us. So we know if we infuse a certain amount, and maybe there's 1% of our tracer in here, that your body is making about 100 times as much. So with a relatively simple procedure, just some blood draws and giving people glucose, we can see how much sugar you're producing, how much fat you're releasing into the bloodstream, and then with the breath testing, how much of that fat is actually getting burned. So how well can your body actually use the agents which are getting released. And so the other thing that we do is the MRI, which for any of the adults, the MRI is marvelous because nobody can say, hey, Dad, guess what? Because you're in the machine alone. It's nice and cool and quiet. And we're all familiar with MRIs generating images. Todd has been working with a very good group, and this is his brain power that's allowed this to happen. What we can look at in the MRIs, we're all familiar with it producing images. What it can also do is it can produce spectra, which tell us how much of a particular compound is present within the tissue you're looking at. So you can look at a particular muscle, and he has a device that he designed himself where the kids can push down, and you can see exactly how much sugar they're burning, how well the muscle is recharging itself in this so-called creatine and phosphocreatine ratio. So this, again, this relatively simple non-radioactive test gives us a lot of information about what's actually going on in the tissue of real human beings. And I'm going to hand it over to Todd, who's the brains behind this operation.
I don't know about that, but we'll see. So
certainly not the brawn.
Okay. So what do we find? So we're not 100% completely done, but we're pretty close. So what do we find? So again, we wanted to look at these measures not only during rest, but low-level exercise. And when I say exercise, I'm talking about really the activities of daily living. Walking, participating in PE, walking down the street, playing with your friends in the backyard, things like that. Not like running marathons or anything like that. So kind of when you see exercise, think of physical activity. These are the types of energy intensity that your boys are participating in. So what we looked at, when we looked at fat use, there's really no difference between control. So unaffected is the black, Barth is the gray bar. When you're looking at rest, they do a pretty good job using fat. But when you give them a little bit exercise, you see it's significantly lower. They're not able to burn fat like the unaffected boys, even at a low level exercise. But then when you rest them again, looks pretty normal. So when you look at how they're using glucose, it looks like they're using more glucose during rest, during exercise, and during recovery. So it seems like they're compensating at least somewhat through glucose use for the lack of fat use. Okay, and that makes sense. If you think about the pathophysiology of the disease, mitochondria, we like, everyone here is basically burning mostly fat, unless you just ate a donut or something like that, but mostly fat at rest. And then when you do low-level exercise, you actually burn fat. But when you do high-level exercise, as Dominic said, you really rely on glucose more. It's a faster energy source, but less energy per unit of glucose. So when you look at protein breakdown, what we initially thought was happening with Barth breaking down more protein, we really haven't seen it, actually. So there's really no differences between the groups here during rest, exercise, or recovery. But again, amino acids, there's so many different amino acids, 20 different amino acids. We only can measure one at a time. So we know that arginine's low. We know that different certain amino acids are low. We use leucine, which isn't typically low, but we use it because leucine is one of the amino acids you actually can burn for energy. But protein breakdown in general was really no different. But when you look at the use of amino acids for leucine, so we originally hypothesized they're using more, but as you see during exercise, they actually use less. And now some of the recent data that's come out in Bill Poo's lab and different things that the energy deficit seems to be all the way at the end when you produce energy called the electron transport chain. So this does not surprise us, so that they're not able to oxidize leucine as well as not being able to oxidize or burn fat as well. But we do, so one more point I do want to make. So instead of burning it, we do think, though, they're using more amino acids to make glucose. And now we're doing some studies now to start to look at that. And then as Dominic alluded to earlier, plasma lactate concentration. So I'm sure everyone here has heard of the lactate burn, right? So when you're exercising at high levels, your muscles start to ache and you want to quit, right? And that's usually associated with higher levels or higher intensity levels of exercise. So you look at lactate levels, so really no difference. It might be a little bit elevated in the Barth syndrome group. But again, at a low-level exercise, in the Barth guys, this really shoots up high. So even at low-level exercise, these guys are feeling probably a little bit, at least, of the lactate burn. And that's probably part of the reason why they don't like to exercise very much, or at least they tire out quickly, because they're generating a lot of lactate, and it's probably not making their muscles feel very good. And then again, a rest after the exercise returns to normal. So this is the skeletal muscle energy production by that fancy MRI that we looked at. So basically, what this shows is how how their muscles generate energy. So these are energetics, like through the mitochondria. And as you see, the Barth guys, as compared to the unaffected group, generates significantly less energy through the mitochondria in their skeletal muscle than their peers. And this is, again, during a low-level exercise bout. Oh, okay. And then also we measured a similar measure. It's not the exact same thing. In the heart, we didn't actually exercise the heart. But this is basically a ratio of energy reserve, how much energy they have in reserve. So basically, if you have a high energy reserve and you start to exercise, you can do pretty well. If you have a low energy reserve when you start to exercise, you're probably not going to last very long. And as you see, compared to their peers, the Barth syndrome group has significantly less energy reserve in their heart. So really, what does this all mean? So energy production through fat and glucose metabolism at rest for these guys do pretty well, actually. They are able to oxidize fat okay at rest. But as soon as you exercise them a little bit, this is when you see the deficits occur. Okay, and they need to basically supplement their impaired fat metabolism. It looks like it's done through using more sugar. And now we're also looking at maybe potentially more amino acids. We're actually looking at arginine as a use to exercise for energy as well, as a reason for why that might be low in these guys. And then some of these measures that we just showed you, we think that are really good physiologic outcomes for these clinical trials. So I know earlier they talked about the 6-minute walk. 6-minute walk is really a surrogate for this peak VO2, this exercise test that we've done. And the questions were absolutely right. Motivation is huge with 6-minute walk tests, which is nice. But they're easy to do. You can do them any clinic. All you need is a hallway, you need a stopwatch, and you need cones, okay, versus doing this exercise test, which you need a metabolic cart, a bike, and all these things like that. But what's nice about the VO2 the exercise test is there's way less issues with motivation. You know if they're giving you a perfect effort by looking at the measures that you're looking on the metabolic. You don't have to worry about, are they not walking fast enough? Because you keep pushing them, you know if they're exercising hard or not. And that's one, so we think that the peak VO2 actually will probably be a better, more specific outcome measure for some of these clinical trials than maybe the 6-minute walk. But again, you have to balance that with feasibility. We also think the MRI energetics is also probably a good outcome measure as well, and potentially some of these tracer studies that we're doing. And it is implications for nutrition therapy, so working with Nicole as far as what do these guys need to get as far as nutrition-wise. And it seems to be that they need certainly an adequate nutrition for protein, and it seems, and they need good complex carbohydrates. So carbohydrates like sugar and these fast, simple carbohydrates are probably not great. So they need to really be, their diets need to have some complex carbohydrates because it seems like they are using glucose to compensate. And it's probably okay, but they need some good complex carbohydrates to do that. And I just want to briefly just tell you about this resistance training study that we've been doing. So a lot of questions are, should these guys exercise? And is exercise good for them? So a lot of you know that we've done an exercise training study, aerobic exercise training study. And the results we just published, and the results are less than we were anticipating. The results were not as favorable as we thought. So aerobic exercise training, basically riding a bike for half an hour to 45 minutes 3 times a week, it was safe, which was great. So no one had any issues with any exercise testing, and this is a 3-month study, so it's safe. But it didn't increase their exercise tolerance as well as we thought. So what we did a couple years ago is we thought, okay, so if they have defective mitochondria, if the mitochondria is not so good, and when you aerobically train, when you train for a marathon or something like that, you actually increase more mitochondria. So we thought, well, maybe they're just making more bad mitochondria. So if we switch to resistance training, which targets basically muscle types that have less mitochondria, that use glucose more, maybe that will be a more optimal way to improve exercise tolerance, to improve quality of life, to make these boys feel better. And so we started this a couple years ago. And what we did is we brought people to Washington University for pre-testing. Again, we did this exercise tolerance, we did strength measures, quality of life, heart function. And then we basically found a physical therapy or cardiac rehab place near their home, and we set up an exercise training program with a physical therapist with them for 3 months, where they 3 times a week they basically went to the gym, did strength training exercises, and then they came back 3 months later at WashU to do some repeat testing. And then recently we also added them doing a protein supplement as well. If adding a protein supplement, is that beneficial when you start a resistance training program? There's a lot of data out there that show when you strength train and you take some extra protein, you actually can build muscle mass and strength gains better than if you don't take protein. And we thought, well, if they're deficient in protein, if they're not metabolizing that particularly well, then maybe giving them a protein supplement would actually be beneficial. So what did we find? So this is basically we were able to study 4 people without protein and then 2 people with protein. The protein study is ongoing. We basically gave them about 40 grams a day. So that was either a shake and or protein bars that you could basically get through GNC or Amazon or whatever. So we specifically used whey protein in this study. It seems to be a little bit better than milk protein as far as building muscle. They went through this exercise training program. And this is really very preliminary data. And what we did is just looked at those who took the protein, which is in red, and those who didn't take the protein. And in the short of it is that everyone got stronger, no matter if you did protein or not. But it seems like their quality of life, this is a Minnesota Living with Heart Failure Quality of Life questionnaire. It seems like their quality of life, if you took protein, actually improved more than it did without protein, okay, and especially on this shortness of breath subscale. And we think this was because their exercise tolerance improved with the protein more than they did without the protein. So in summary, we thought that everyone, the kids or young men, if they participate in a strength training program, everyone gets stronger. But if you actually add protein on it, they've seen they might improve their exercise tolerance a little bit better, and their quality of life might improve. So we're continuing the work to go down this line to see if this is really true. Again, this is a very small sample size. But I think the take-home message is that exercise is safe. We've done now probably close to 100 peak exercise tests with no issues. We've had now about 12 people go through either endurance or resistance exercise with no issues. So we think that's a great thing. And we think that now resistance training appears to be more beneficial than endurance exercise training in these boys. So looking ahead, we're hoping to complete this metabolic study that I talked about earlier within the year. We're doing some more in-depth study of this carbohydrate metabolism. One of our young faculty, George Schweitzer, is here, and he's kind of heading that up. We're doing these molecular cell studies with Christy Pasak and Barry Byrne at UF. We're continuing these strength training studies. And then obviously the ultimate goal is to do this gene therapy trial with Christy and Barry, and then use a lot of these outcome measures that I've talked about earlier as well. And what I'd like to do, well, first I want to thank the group that's been working with it. Obviously Dominic's here, Kay's here, Barry and Christy are both here. A couple other people from WashU that's been super helpful. But what I really want to do is just for a couple minutes bring up a couple people that's participated in these studies to tell their experience about it. So Andrew and Jack, if you guys want to come up and just talk about your experience.
Okay. I think I've done all three, right?
You've done all three.
Yeah. I mean, so none of them were like terribly bad. And I mean, I think from all of them, I mean, the one you don't really feel an immediate benefit, but definitely the strength, and both the endurance and the strength, I felt better afterwards. I don't know.
Yeah.
If you want to
I felt,
come on those.
while doing it, yeah, I was definitely felt better, stronger, and just overall well. So, yeah.
Okay. I don't know. Do you have anything?
Well, no, I mean, I think I also participated in all three, and
How were the procedures? I mean, how did you tolerate the testing?
fine, you know.
Not an endorsement I was hoping for.
No, they weren't bad at all. And I mean, it's nothing that you haven't dealt with before, and it wasn't terribly uncomfortable. My brother who's here as well, did it, and they kept having to wake him up. So I think he was too comfortable in some of the procedures. So, yeah. Anything? Oh, okay.
Okay, well, and with that, we'll take some questions. Dominic and I will take some questions. Oh, I'm sorry. Yeah. Aaron, go ahead. Oh, no, I didn't turn it off. It's on.
If the peak VO2 testing is a more accurate representation than the 6-minute walk, and you have a lot of those results, would you be able to plot them on the same kind of chart that Brittany's 6-minute walk was plotted on, so that we could see across the ages whether there's a degradation?
So basically a natural history of peak VO2, yes, that would be ideal. So again, you have to balance the feasibility versus the accuracy, right? So the 6-minute to walk test they're starting to collect them in the clinics as well. And so that would be an easier, more feasible thing to like do a natural history over the course of the years. But we have enough data on the peak VO2 and on a bunch of these guys that we could over the years plot that as well and see. But I am not seeing, well, again, I don't have that much of I only have maybe a 10-year span, but I've not seen a progressive decline over the years in the guys that we've done.
But even what she had was the one point in time comparison of younger versus older. You probably could do that from the data that you already have, right?
Correct. And it's, okay, yeah, we definitely could do that.
Hi, I was curious about how the aerobic exercising and the resistant training could translate into the younger kids. We have a 4-year-old and how he can be looking, you know, obviously he's not going to the gym lifting weights right now, but just what we can be doing to make when he is old enough to do that better, easier,
Right.
better quality of life.
Yeah, that's the challenge, right? It's a challenge for adults, finding something, a way to incorporate this that someone will actually do. And yeah, a 5-year-old is not going to go to the gym and lift weights. So I think it's probably good to work with a therapist or try to do some sort of activities that he really enjoys to do to help build the strength and core strength. I think a lot of it is playing. Playground stuff is great. Climbing, things like that is really can build some core strength and really work on that. I think the big take-home message is you can let these kids play. And they're going to probably self-select when they're tired. They'll probably dial it back, and when they're feeling better, they'll go. But I think the take-home message is that they can safely do this.
One more follow-up. How do you, since you can tell that their exercise tolerance like really physically maxes out much quicker than a peer, how do you recommend either pushing or not pushing, knowing that they can self-regulate, but not allowing them to get lazy or dependent?
It's a great question. So it's probably the overall answer to that is really kind of knowing your kid and knowing when he's really saying, I am really not feeling well, I'm not tired, and saying, I'm just lazy, I don't want to do it. So there's probably some of it being able to push a little bit, but probably not over, like you can just do it and just go out and do it. So it's probably knowing, I mean, you know your kid, and when they're really tired, and probably when they're just dogging it a little bit. Yeah.
Thank you.
Can you tell me if any of these participants in your research are on amino acid supplements and if you saw a difference with their outcomes?
Yeah, it's a great question. So I would say a good amount were on amino acid supplements. For these studies, we actually had them stop for the 3 days beforehand, just because it could confound our results when we're looking at amino acids metabolism and they're taking these loads of amino acids. So we did not look at the difference between those on amino acids and not. And that's the big conundrum. A lot of the kids are on these amino acids, but we've never really systematically studied it. And it's really hard to say, can you go off your amino acids for 3 months or 6 months, and then we can study you and put you back on and all that. So I don't have those data. I don't see a huge difference right away, but that is a problem. We don't know how effective they are, but no one is really willing to go off them to study that. Yep. Oh.
The amino acid question got me to thinking about, what about heart medications that they're on? Because I know some heart medications prevent them from overexerting themselves or getting into, I don't know scientifically.
Yeah, it's a great question. So things like beta blockers, so we didn't take them off their heart medications, obviously, but things like beta blockers can blunt heart rate responses and things like that. So we obviously, so there's other measures when you do an exercise test. So some of the criteria for saying someone's at a peak exercise test, the main one is looking at their heart rate. But if they don't have, if their heart rate's not reliable, someone's on a beta blocker, we look at this RER value, and that can tell us a lot more if they're actually at peak exercise or not. So certainly that has an influence on it, but we don't think it had much of an influence on the metabolic data.
I just wanted to know if you'd done any studies on boys that had been transplanted and what the results were from that.
So that's a great question. We hope to do that. So for this study, we did not, because we were interested in how the heart and this muscle metabolism and how that related to heart function. If we had a different heart, we really wouldn't be able to make that connection. But we were hoping to look at the transplanted boys at another point, because transplanted boys still have the Barth muscles, skeletal muscles that are impaired, that we want to make sure we can study and figure out what the best means to treat them as well. So we're hoping to do that in the future.
Hi, I was just going to say that I'm doing a session tomorrow at 9:30 on some of the stuff that I found from the UK clinics, but kind of practical top tips. So it's lots of the stuff that's coming up today in terms of pacing and fatigue management, how much is too much. All of that's going to be covered in a session tomorrow, kind of 9:30 till 10, which is also covering the kind of physio sessions that Brittany and I did with the boys yesterday, showing some photographs, showing some videos of what they did. So probably some of the other questions might come out
Yeah,
in
thank
that
you
session
again,
tomorrow.
Lucy. Yeah, absolutely. That would be great.